Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar, and today we are going to discuss one of the MCQs that we put up a couple of days ago in the Telegram channel. The MCQ number was 246, and the question was most common nerve involved in fractures of surgical neck of humerus is. It's a very straightforward question. All of you got it right, and the answer is axillary nerve. Okay, the axillary nerve is in close association with the proximal part of the humerus, and therefore it's commonly involved, and it's very clearly known. So let's go through a few of these things about proximal humerus fractures and some nerves of the upper limb, so that we understand and we reinforce our concepts regarding these things. Right, so all of us know the what is the origin of the axillary nerve. Axillary nerve comes from here. So just a brief recap of the brachial plexus. I always go through the brachial plexus recap so that it reinforces for you and it's easier for you to remember this. So brachial plexus is formed by the C5 to T1 nerve roots. 5 and C6 become the upper trunk, C7 becomes the middle trunk, C8 and T1 becomes the lower trunk, and all the trunks become anterior and posterior divisions, right? And all the posterior divisions combine to form the posterior cord. Why is it called the posterior cord? Because it is posterior to the axillary artery. The anterior division of the upper and the middle trunk combine to form the lateral cord, and the anterior division of the lower trunk continues as the medial cord. The posterior cord gives away the following branches: upper and lower subscapular nerves, that is a nerve to the subscapularis muscle, and then you have the thoracodorsal nerve to the latissimus dorsi, thoracodorsal nerve to the latissimus dorsi. Then you have the axillary nerve, is a big branch, and that is what is the basis of our discussion today. So the axillary nerve comes off from the posterior cord, right? And the root value for the axillary nerve is C5 and C6. The root value, or where it usually comes from, is from contribution comes from is C5 and C6. The terminal branch of the posterior cord, all of us know, is the radial nerve branch. Okay, so axillary nerve comes off from the posterior cord. It is a C5 and C6 nerve roots, and it has close. What space does it come out from? It comes out from the quadrangular space, right? Quadrangular space. What are the six? It is in close association with the proximal humerus bone, and therefore can be easily injured in those fractures there. So what is the muscle supplied by the axillary nerve, right? The axillary nerve supplies the deltoid, all portions of the deltoid, anterior, medial, and posterior portions of the deltoid. It also supplies the teres minor muscle, and it also gives sensation to the lateral portion of the upper part of the arm. You can have decreased sensation in this region, and this is called as a regiment patch sign. Please remember this. This can happen in dislocations of the shoulder. It can happen in fractures of the proximal humerus. Now coming to the fractures of the proximal humerus, the proximal humerus has two heads, right? You have the anatomical head, which is right here. Anatomical head is where the growth plate was there previously, growth plate which has fused, and then you have the surgical head. Why is it called the surgical head? Which is more distal and more inferior to the anatomical head. So this is the anatomical head, and this is the surgical head. And why is the surgical head and anatomical head different? Because the fractures in most locations occur through the anatomical or the pre-existing growth plate, but in case of proximal humerus, the fractures most commonly occur at the level of the surgical head, or that is below the level of the previous growth plate closure area, or below the anatomical head, and this is called the surgical head because this is where the fractures occur more frequently for some reason. Okay, and the reason is theoretically hypothesized to be because there is a large metaphyseal area. It is a little more weaker than the anatomical head, and therefore it tends to more commonly fracture at that area. So this is the difference between the surgical head and the anatomical head in the proximal humerus. Okay, so the proximal humerus basically has four parts. I mean, it fractures in four parts, right? So it fractures in the lesser tuberosity. What is the lesser tuberosity? Lesser tuberosity has an insertion of subscapularis muscle. Then you have the greater tuberosity, which has the following muscle attachments: SIT from superior to inferior, SIT, SIT supraspinatus, infraspinatus, and teres minor from superior to inferior. Between the greater and lesser tuberosity, you have a groove through which the long head of the biceps tendon passes through. Okay, what are the deforming forces that act on a proximal humerus fracture? The lesser tuberosity is pulled inwards or internal rotated by the subscapularis. The greater tuberosity fragment is pulled superiorly and posteriorly by the SIT group of muscles, that is a supraspinatus, infraspinatus, and teres minor group of muscles. Then you can have a surgical neck fracture that happens at this area. This area can happen. So you have a greater tuberosity fracture, you have a lesser tuberosity fracture, surgical neck fracture. And then the shaft is pulled by what is called as the pec major. Pec major internally rotates and adducts the humeral shaft muscle. So these are the deforming forces in the proximal humerus. Proximal humerus can have 4 pieces. The first piece is the lesser tuberosity, second piece is the greater tuberosity, third piece is the head through the surgical neck, the fourth piece is the shaft. And the shaft is pulled inwards and internally adducted and internally rotated by the pec major. These are the deforming forces in the proximal humerus fracture. Then one important thing you must understand with proximal humerus fracture is called the Neer's classification. Okay, he classified based on displacement, based on the displacement of the fractures and the number of fragments Okay, it doesn't depend how many fragments are there, but if the displacement is less than 1 centimeter and less than 45-degree angulation, it is called as one part fracture. It doesn't depend how many fracture lines are there, but if the fracture is not displaced beyond 1 centimeter and is less than 45-degree angulation, this is called as one part fracture. If the displacement is more than 1 centimeter and more than 45-degree angulation, it is called as a two-part fracture. When two pieces are fragmented more than 1 centimeter and more than 45-degree angulation, it's called a two-part fracture. When there are 3 parts and the angulation is more than 45 degrees and more than 1 centimeter displacement, 3-part fracture. When all 4 parts of the proximal humerus are fractured with displacement, it is called as a 4-part fracture. Okay, so you must remember this. Neer's classification is very frequently asked. Less than 1 centimeter and less than 45-degree angulation is one part fracture. Doesn't not matter how many fracture lines or how many fragments are there. More than 1 centimeter and more than 45-degree angulation indicates a displacement, and depending on the number of parts of fracture or number of pieces, you can call it 2-part, 3-part, and 4-part. What are the 4 parts that can be fractured? Lesser tuberosity, greater tuberosity, surgical neck of humerus, and the shaft. These are the 4 parts that can be that we can see in proximal humerus fractures. Okay, so the answer to the question was basically axillary nerve, because axillary nerve is in close association with the shoulder. It's anything to do with the shoulder dislocation, shoulder fractures. Then you must always guess the axillary nerve, because that is the one which is in close association with the shoulder problems. So let's look at the common nerve injuries in the body. And what are the presenting symptoms, so that you can answer these MCQs very easily when they show up in your exam. So you know what is the long thoracic nerve, or the nerve of Bell, right? Bell's nerve, it's also called as Bell's nerve. It supplies what muscle does it supply? It supplies the serratus anterior. Serratus anterior, and if you have a palsy of it, you can have what is called as a winging of scapula. Winging of scapula is seen in long thoracic nerve palsy, and it affects the muscle serratus anterior. Axillary nerve, we just discussed, can be affected in cases of shoulder issues, shoulder dislocation, shoulder fractures, etc. And this will affect what muscle? It will affect deltoid, and it will prevent abduction of the shoulder. You will also have a sensory loss in the lateral aspect of the upper third of the arm, which is called the regiment patch sign. Then you have the radial nerve injury. If radial nerve is involved, you have wrist plus finger drop. if you have the posterior interosseous nerve, which is a branch of the radial nerve, the radial nerve divides into the posterior interosseous nerve and the superficial radial nerve. So once it becomes posterior interosseous nerve, it's already given off its branch to the ECRL, extensor carpi radialis longus, and therefore the wrist extension is preserved, and so therefore you'll only have a finger drop in case of posterior interosseous nerve palsies. You'll have only a finger drop in posterior interosseous nerve palsies. Where do you have radial nerve injuries? You have radial nerve injuries very commonly in the humerus shaft fractures. And which type of humerus shaft fracture? More specifically, it's called the Holstein-Lewis type of humerus shaft fracture, where you have this injury, which is more common. Then you have median nerve injury, right? Median nerve injury can affect your some of the intrinsic muscles of the hand, thenar muscles of the hand. It can also affect the medial FDP and the FDS tendons as well. Okay, median nerve is very commonly compressed, where it is compressed to the carpal tunnel, and therefore you have the tingling and numbness in the lateral 3.5 fingers, carpal tunnel syndrome. Then you have the anterior interosseous nerve. Anterior interosseous nerve is a branch of the median nerve. It supplies the FDP of the index finger, FPL of the thumb, and pronator quadratus. In which condition is affected most commonly? It is affected in supracondylar fractures in children. In supracondylar fractures, you have this pressing on the anterior interosseous nerve, the fragment, and therefore it causes the anterior interosseous nerve problems. And patient cannot make a OK sign. This OK sign cannot be made because he cannot flex the FDP of the index finger or the FPL. So this is called the OK sign. It's also called as the Kilo-Nevin syndrome. Kilo-Nevin syndrome. So this is the anterior interosseous nerve syndrome, or Kilo-Nevin syndrome, or OK sign, inability to make the OK sign. Then you have the ulnar nerve injury. Ulnar nerve injury, what does it cause? It causes clawing, very famously clawing. Clawing is inability to flex the MCP joint and extend the PIP and DIP joint. This is called the claw hand, and this is very commonly seen in injuries. Okay, and we have discussed this extensively in other videos. Please take a look at it. Then you have the peroneal nerve, is a part of the sciatic nerve. It's the most common portion of the sciatic nerve to be involved, and it will cause a foot drop because the tibialis anterior, the extensor group of muscles are affected, and patient will not be able to lift the foot up. So this will cause a very common injury. It's called a foot drop injury. It has poor prognosis. Among all these nerves, which has the best prognosis? It is the radial nerve which has the best prognosis, because it has almost a pure motor component, and therefore it recovers very well. Then you have the femoral nerve injury, which is very uncommon, and it supplies the quadriceps muscle and causes weakness of knee extension. So femoral nerve injury is extremely uncommon. Then you have the tibial or sciatic nerve injury. So the tibial nerve is also a component of the sciatic nerve. The sciatic nerve has two components. The sciatic nerve is two components. You have the tibial nerve and the common peroneal nerve. Common peroneal nerve is more commonly affected, whereas tibial nerve is very less commonly affected. And if the sciatic nerve is completely affected in cases of hip issues, hip dislocations, then the whole of the lower limb is affected. All the function of the lower limb is affected. This is in brief about the nerves and their function and their common injuries that can happen in the body, and these are the questions that are commonly asked. You must recap this very frequently. Make sure you're not missing any of these questions, and this is a very straightforward question. You usually get one or two of these in every exam. So I hope this clears a few of your doubts and reinforces some of your concepts. And thanks for hearing me out. My name is Dr. Kannan, and this is Plexus Ortho. Thank you very much.